everybody. Now, exclusive breastfeeding has the single largest potential impact on child mortality of any preventive intervention. So how do we make it happen? And what do we know about what is effective in increasing exclusive breastfeeding rates? Well, we've known since the 1990s that general messages proclaiming the benefits of breastfeeding are just not effective. Telling a mother that breast is best, telling a mother what to do, that is not going to enable her to breastfeed more. Women need support if they're going to breastfeed effectively. Well, what kind of help do mothers need? There are reports of many studies, but they all use different words, like guidance, which is vague, promotion, which is different from help, as we've just said, education, which can be confused with messages, and support, which is often used, but that means for many things in many different ways. Breastfeeding counselling is by far the most specific term. Well, interventions are not often described very clearly in the studies, and they may be multi-component combination with BFHI and other interventions. So intervention needs to be a consistently named, clearly described, and evidence-based, and it needs to be public health policy. Well, I'm sure you'll all remember the Global Strategy for Infant and Young Child Feeding, and that talks about improving of breastfeeding practices. But it's not really very clear what it means by this. It talks about mothers having access to skilled support. It talks about knowledgeable health workers without mentioning how they should be trained or what they should be trained to do. It talks about mother-to-mother support and trained breastfeeding counsellors, but never is breastfeeding counselling mentioned, even though it was already in use for about 10 years by that time. There are also many reviews of many different studies, and they all, interestingly, come to rather similar conclusions. Most kinds of help result in some increase in exclusive breastfeeding. Professional help and lay help are both effective. In fact, interestingly, lay can often be better than professional help, but they're really best if they're used together in a team. Face-to-face contacts are usually better than telephone contacts. But a very important point is that help which is offered only if women seek help, which is unlikely to be effective, women should be offered predictable, scheduled, ongoing contacts, such as home visits in the community or at the health facility. Frequent contacts are necessary. Numbers that are often mentioned are 4 to 8 plus antenatal, but postnatal is usually more effective than antenatal alone, and more than 8 contacts is often also helpful. Practitioners, lay and professional, they need specific practical training. They also need supervision, and for sustainability, they're going to need remuneration. Volunteers do not last for very long. Now, what's the origin of breastfeeding counselling? To me, it goes back a long time ago, over 60 years, when La Leche League started mother-to-mother support. La Leche League was, in fact, the first organisation to start the breastfeeding movement, which we often forget. La Leche League leaders learnt to help effectively using basic counselling skills, to listen, to empathise, to build mothers' confidence, and practical clinical skills as these developed. For example, positioning and attachment of the baby at the breast, which was worked out in the 1980s. Now, out of La Leche League work developed 2 other groups of people, peer counsellors who were used for community work mainly, and lactation consultants for more specialist and medical approach. The title breastfeeding counsellors became used by various voluntary groups, but breastfeeding counselling was introduced by WHO and UNICEF into the BFHI and also infant and young child feeding related training courses, which were being developed for health workers from 1993 onwards. The term counselling is very important. It's recognized as being necessary to distinguish it from advising mothers and telling them what to do, which a lot of health workers use in health education. They're telling mothers what to do. But breastfeeding counselling is the clearest and the most accurate title for the intervention that we're talking about, and it needs to become a standard public health intervention. Now, what about the breastfeeding counselling, a training course, which was the first course of its kind, and that was developed by WHO and UNICEF in 1993. It was 40 hours long. That takes about a week. And it also included training of trainers, which is very important. It was revised in 2013, but in the meantime, it had been adapted for many different situations. For example, pre-service curricula, community counselling, humanitarian settings, and for many others, for what was particularly needed in a particular country. Now, the general approach that it takes, which is supporting the normal, as we have with midwifery, which is supporting the normal delivery of babies, not waiting for a problem to develop, which is what happens with most medical interventions. The knowledge that's required to back up what we're recommending the intervention should be is the basic physiology of what is needed for successful breastfeeding, initiation, establishing, and maintaining. The competencies that the course tries to develop in participants are, first of all, basic counselling skills, which is to communicate with mothers, with listening, empathy, confidence building, and helping them to decide. And also practical competencies, help with positioning and attaching the baby at the breast, responding to the baby, developing the feeding pattern, and managing common difficulties. But the training itself, it's not just a series of lectures and talks. It also includes a number of exercises, a number of demonstrations and practicing in the classroom. But the most important thing is 8 hours of clinical practice with mothers and babies. That's usually 2-hour sessions on each of 4 days. And that's where people really change their attitudes and they get their understanding of what's supposed to happen. Now, breastfeeding counselling in community settings, just as an intervention by itself, is very effective. And here are just 2 examples of many different projects and studies to demonstrate its benefit. One by Morrow in Mexico, using La Leche League style of training, which, as I've said, is the basis actually for the breastfeeding counselling course. And she found that 3 contacts increased breastfeeding compared with the control by 5 times, and 6 contacts even more, up to nearly 70% of exclusive breastfeeding. And Ruxana Haider in Bangladesh did some very important formative work there, and she showed that 15 contacts with breastfeeding counsellors trained on the WHO course increased exclusive breastfeeding to 70% compared with less than 10% of the controls. Another way in which breastfeeding counselling can be introduced is by primary healthcare workers. And this is done by Nita Bandri in India. They had primary healthcare workers who were already trained to work with mothers in various interventions with immunization and treating babies for primary care conditions. but they trained them using the breastfeeding counselling course or an adapted form of it to include breastfeeding counselling in these various multiple contacts that they had with mothers from birth. And you can see that from the chart that the babies who were involved in the intervention, they had much higher breastfeeding rates than the babies who did not receive counselling. At 4 months, 70% of them were exclusively breastfeeding, and still at 6 months, over 40%. There's a very valuable systematic review and meta-analysis by McFadden, which is recently published, on counselling intervention. Now, this is the first systematic review which actually mentions counselling as the intervention, which is interesting. Ones before were all talking about support or something else. And her main conclusion is that breastfeeding counselling is an effective public health intervention to increase rates of any and exclusive breastfeeding. Now, what about the impact of the baby-friendly hospital initiative on breastfeeding? Doesn't that do the same job? A lot of people believe that it should. However, there was a study in England, and I think there have been others, similar ones, which showed that although babies born in a baby-friendly unit were 10% more likely to initiate breastfeeding, by 1 month they were no more likely to breastfeed than babies who had not been in a baby-friendly unit. So the baby-friendly initiative increases initiation, but not necessarily continued breastfeeding. And Perez Escamilla in 2016 did another review, and he found that for the BFHI to have a lasting impact on breastfeeding rates, step 10 was the really important one. And of course, step 10 is the one in which mothers may be referred, and hopefully they would have counselling continuing for some months after the baby was delivered. So the BFHI, including most particularly step 10, is going to have a lasting impact on breastfeeding. Now, there is another study which was done in Brazil, and I hope that Dr. Coutinho is here today, or if she's around, that she compared babies who were born in a hospital where the staff had been BFHI trained. So I think they hadn't actually been designated as baby-friendly, but they'd all been trained and they were practicing baby-friendly practices. And then half of them had continuing home visits from breastfeeding counselling trained health workers. And you can see from this chart that the control mothers who didn't have either of these things had very low rates of exclusive breastfeeding. The ones, the dark blue, in the dark blue columns, both of the hospitals, the BFHI trained one and the BFHI trained plus the home visits, they both had very high rates of exclusive breastfeeding when they were discharged, about 65%. But those who did not have home visits, their breastfeeding rates went down very quickly from 10 days after birth to 30 days after birth. They were very low, only little over 10%. But the ones who had had home visits and breastfeeding counselling, their breastfeeding rate remained much higher. In fact, at 10 days, it was higher than the ones who at 1 day. And at 30 days, it was still as high as when they had been discharged from hospital. It gradually decreased, but it still remained much higher up until 6 months. So that is a very important observation, that having home visits and breastfeeding counselling after delivery is what is necessary to maintain breastfeeding. You may have heard of the warm chain for breastfeeding, and I know that there's going to be another session on that. at some time in the conference. And this is thinking about integrated support for mothers and babies throughout the continuum from the facility to the community. And this is a campaign which is being promoted by WABA. And there are two other reviews by Sinha and by Kim, which both also show that breastfeeding from the baby-friendly hospital, where it's promoted there, and counselling afterwards are both very strong ways to promote exclusive breastfeeding. And Kim says very specifically, the counselling intervention is most effective when it's multi-component, combined with the BFHI, and when hospital and community settings are connected. Now, very excitingly, I think, WHO has developed guidelines on counselling of women to improve breastfeeding practices, which moves it into a much higher policy level as something that should be introduced in public health. And their recommendations are that breastfeeding counselling should be provided to all pregnant women and mothers with young children, in both the antenatal period and postnatally, and up to 24 months or longer, at least 6 times, and additionally as needed, through face-to-face counselling, and in addition by telephone and other remote modes of counselling. I don't know if you can counsel on Twitter, but I'm sure there are lots of ways in which it can be done quite helpfully. As a continuum of care by appropriately trained health professionals and community-based lay and peer breastfeeding counsellors. And the last recommendation is that breastfeeding counselling should anticipate and address important challenges and contexts for breastfeeding, in addition to establishing the skills and competencies and the confidence among mothers. I think this recommendation covers what was said in some of the earlier papers, that mothers need regular, scheduled, predictable contacts, not to wait for a problem. So this is covering the same concern, but a little bit more widely, and looking at other problems like what happens when she goes back to work and so on. Now, these to me are very important and very exciting movements that are beginning to happen in the breastfeeding world. And what it seems to me is really, really important is that we must be promoting breastfeeding counselling. In the past, people have tended to slip into promoting breastfeeding. Now, breastfeeding is not an intervention. Breastfeeding is a behavior which mothers are responsible for. What we need to promote is breastfeeding counselling to help mothers. Now, the guidelines from WHO, the implementation guidance that goes with them, which gives a better idea about what people actually need to do, how to do it, that hasn't been developed yet. It's in the process of being developed. But there are a number of major considerations, and this is not what has been written down by WHO. These are my reflections on it. We need to define the intervention according to relevant categories of professional and lay practitioners and teams. Developing plans for reaching all pregnant women and mothers of young children. How do we reach all pregnant women and mothers of young children as a standard part of care in all settings? This is a major undertaking. Recommending training protocols for the different categories of counselling and training of trainers and supervisors. That must not be forgotten. Just training counsellors and not training more trainers it'll make it impossible to extend it through the whole population. working out the time needed for the necessary tasks, and considering the necessary deployment of personnel. Who is going to do the tasks? Who is actually going to do the counselling? And the time that it will take them, and the capacity costs, the cost in terms of staff time and the financial costs of implementation. And of course, as always with an important care initiative, devising methods of monitoring and evaluating it. But above all, what I think we must think about at this point, when we don't yet have the implementation guidance to work from, we must think about advocacy for breastfeeding counselling. And this is something we need to be very strong about. Thank you all very much indeed.